It is with great pleasure today that I introduce our presenters. So Ashley Din is the Provincial Program Manager of Virtual Care at the Newfoundland and Labrador Centre for Health Information. She leads a team responsible for supporting and implementing virtual care solutions across the 4 regional health authorities. She also leads the Registry Integrity Unit and who maintain data integrity in the client registry. Ms. Din has a Bachelor of Business Commerce and a Bachelor of Nursing from Memorial University. As a registered nurse, she worked in long-term care and acute care before joining virtual care. She has expertise and leadership in supporting virtual care services across the healthcare sector. And with her is Leah Carey. She is the Provincial Program Manager of Community Health at the Newfoundland and Labrador Centre for Health Information. She leads a team responsible for education, training, support, and enhancements to multiple community health documentation and assessment tools. Ms. Carey has a Bachelor of Nursing degree from Memorial University, and as a registered nurse, she's worked in acute care, critical care, long-term care, community health, and clinical information technology prior to joining the leadership team for community and virtual care at NELG. So without any other delay, Ashley and Leah, it is over to you.
Thank you, Peggy. All right. Ashley, if you want to hop to the next slide. So today we're going to walk you through how digital health solutions can enable your nursing practice with a focus on tools in our specific areas of community and virtual care. Some of the key messages and themes you will see throughout the presentation are how these tools can improve faster communication, more efficient charting, can help increase patient safety and improve quality of care, along with improved efficiencies and improved patient experience. I'm going to pass it over to Ashley now, who will start with the virtual care component.
Okay, so the Provincial Virtual Care Program has responsibilities across the 4 regional health authorities, but we also support private organizations as well. So we have a large number of stakeholders that we are engaged with, and we have we're broken up into regional teams to best support each of the areas deploying virtual care services. So I guess virtual care is a very broad term. So we have adopted the one from the Canadian Medical Association. So virtual care is defined as an interaction between patients and or members of the circle of care occurring remotely using any form of communication or information technology with the aim of facilitating or maximizing the quality and effectiveness of patient care. So with that could include standard technology where the provider can connect with a patient, client, or resident. And the method would be, it does include phone, email. We use telehealth interchangeably with virtual care. So that would be the video conferencing side of it. There's also secure messaging, and remote patient monitoring would fall into the realm of virtual care. So with that, there are a number of solutions that are available within our umbrella. Our most used solutions right now is Jabber and Cisco. So we have a provincial Cisco infrastructure and Zoom for healthcare. So it is a tailored version of Zoom that is meets the secure standards for the health system. And then our telehealth endpoints and units. So those are the ones that you would see within a regional health authority that would support clinical encounters. So I think the biggest thing I wanted to kind of bring it back a little bit to before COVID of where we are, because it really shows where we've come today and the advancement that we have made in a very short period of time. So prior to COVID, we had a high focus on facility-based telehealth appointments. So these would be standard-based appointments where a client would have to travel to community health or regional health authority to participate in an appointment by video. So this would be, they could be unattended in a room, or a clinical staff could be supporting them, connecting with another provider. And we did have, there was this a smaller set, I guess, of departments that were participating. So areas like cancer care, nephrology, mental health and addictions were some of our large areas. So we had a provincial scheduling. So this was a centralized scheduling. It was outside of other scheduling methods such as like Meditech or EMR. This is a different area, and it is because we're doing the scheduling of staff to coordinate booking the equipment as well. So it was kind of a burden prior to COVID, just because it was an additional tool that we had to use. Telehealth expansion project, so that had just finished in 2019, and the goal of that was to really expand our reach for virtual care services. So there was a number of areas that we planned to expand to, and we had only really just finished deploying the last few units, and really working on the uptake and the expansion models prior to COVID. So we weren't seeing the full expansion that we wanted yet, but this is where COVID kind of put us into trajectory. So home-based technology. So this was the piece we did during the expansion. So this was allowing clinicians to connect with clients in their home. So this was rolled out across the regional health authorities. It was a slow uptake, and just really working through the change management process. And then I just mentioned the compensation. I know it doesn't apply to this group, but that was one of our main reasons why facility-based appointments still were our main area. So early in the COVID response, so we had a virtual care kind of emergency response. So how to keep services going at the bare minimum, and then we kind of worked to enhance the services as we went. So facility-based, there still was a requirement for facility-based. It was deemed to only necessary. So this is when a client needed some hands-on assessment to facilitate the appointment. So this could have been, areas like wound care, dialysis, and cancer care were some of the areas that did still proceed with facility-based. So we did enable direct booking. So this allowed clinicians to directly book their appointments through our scheduler. It took away that back and forth and delays of getting appointments scheduled. So it allowed for a quicker turnaround. We did deploy a provincial support model. So it was 24/7. It has kind of scaled back a little bit now as we've moved into our, I guess, somewhat of a new normal. But this model really allowed, this was the first time we had a patient-facing access. So clients could call in, were unfamiliar with technology, and could get additional support to be successful. We did deploy a new virtual care website. It was tailored to COVID, and we're now in the phases of kind of revamping that to move forward and not have all of the virtual care components that we originally had. But it was a kind of a one snapshot area where you could look at the various tools for virtual care and get as much information from one source as possible. We deployed device testing. So this was something we found was really helpful for clinicians to, determine the client might be suitable for that use case for an appointment, but do they have the right technology to be successful for the appointment? Also, where a lot of clinicians were working from home and had to use their own personal devices early in the pandemic, this allowed them to check their own devices to see if they could be successful with providing virtual care. And then home-based, certainly that expanded rapidly for us, which was great to see. We were able to get a significant number of clinicians onboarded in a very short period of time to allow them to keep their services going if it could be done by virtual. And then overall, we just saw a mass increase of virtual care services. So there was a number of areas that, didn't seem that virtual care would meet their clinical needs. And, everybody kind of had to take a look at how to evolve their services to see, where virtual care could fit to continue care. So during the deployment, there was a couple areas that were the biggest ones for us. So the iPads were deployed. There was over 500 iPads, probably 600, I think, in total, that were deployed across the the 4 regional health authorities. So this allowed connectivity across the regional health authority. So it could be that personal care homes, long-term care facilities, and even between floors. So this allowed clinical rounds to occur without by decreasing the movement of staff. That was the biggest piece that we're trying to do. It helped decrease the use of PPE. So the iPads were inside rooms with a client, and the provider would, instead of a call bell system, they would actually call out and help answer some questions and determine if they should gown up and go into the room to see the client. It allowed staff that weren't able to go into long-term care facilities ability to connect with the residents, which was great. And it was one of our, a new area for us to really expand. And then the acute care floors, again, we were able to allow, consultations. And then we also tied into virtual visits with families. So it kind of had a multi-purpose. And we equipped the CDC nurses with iPads and phones so that they would have cellular access when supporting clients, into their homes and other areas, just with the way the testing sites were coming up so quickly. So then the second one was Zoom for Healthcare. We had originally just our Cisco infrastructure, which would have been Jabber and our telehealth endpoints, but Zoom for Healthcare really allowed us to connect easier with clients in their home. It was a technology that they were very familiar with, and the success rate was higher just from connectivity and stuff like that. So it allowed, different areas to kind of proceed that wouldn't have necessarily been able to if they had stayed with Jabber. So this is just a map of our telehealth sites. We do have to do a little bit of an update, but the last time we ran this, it was 210 sites. We do have a number of sites that have been deploying, so I'd say this number is going to grow in the next few months. But as you can see, there is good coverage across all the sites. So between the community health sites, the regional health authorities, there is an ability for either clinicians to use a telehealth unit or a client to come in to connect when required. So the biggest thing is with all of our platforms, they are secure, they're end-to-end encrypted. So it allows connectivity no matter what device is being used, which has allowed for success. So this is the device checker that I had just mentioned. I just put it up there so you guys would have the link. And the biggest thing is it's really hard to determine, what kind of device the client has, if it's been regularly updated. So without having to put that additional burden on clinicians to try to figure out why somebody's successful or not, they could just run this device check and it would tell them that they're optimal. No indications that the appointment won't be successful. Adequate means, bandwidth might be a little bit spotty, or they could do with an update to the phone, and inadequate would show that it is not suitable and a different device or a different method would need to be planned. So some of our virtual care highlights over the last 2 years, we wanted to just kind of show that there are over 3,000 virtual care licenses deployed. And I did do a check earlier today. I think we're getting close to 4,000 now. So the licenses are staying. People are using the technology that has been deployed early in COVID. So it is a large amount, and it is a mix of RHA, and there are some private clinicians as well. And we actually did. We've cleaned up all of our data because we did such mass onboarding, but we've actually scanned all of our data so we can actually report now on the clinician. So if it's a registered nurse, allied health workers, physicians, we can actually do breakdowns now of those for different reporting across the province. And at our highest peak, there was about 130 concurrent calls. So that's calls all at the same time, which is a significant number. That number is obviously dropped now with the mix of in-person, but it does show that we were able to hold a large amount of calls all at the one time successfully. And just in, between September 1st and the 30th, there was 5,000 calls alone in that month. Whereas, I think it was quadrupled calls from the previous year. So it's been really significant, and our numbers are still holding pretty strong. We expected to taper back, but it is really high still. So for new virtual care appointments, now as we're kind of settling into incorporating virtual care as part of our, the care delivery model, virtual emergency rooms is one of our biggest areas of expansion right now. So we have, I think there's about 8 across the province. So this is supporting a couple of different pieces that kind of drive it, but most of it right now is the physician shortages. So it is allowing Category A and Category B sites to connect. It's using protocols to review the clients so that they need to be bypassed and go directly to Category A versus if they can be seen virtually through the technology. So with this, we have digital stethoscopes, high definition examination cameras, and our robust telehealth carts. So that allows a really good visual of clients and gives you access to the auscultations as well. And the horoscope, it's called a GEDMED horoscope. It's the examination camera. And that one has a high definition examination camera, an otoscope, and a dermoscope is the other one. So if you need to look at a lesion or look in the ear, they're really great for helping with diagnostics. And then the last one is the NICU. So we have our plan over the next years to deploy to all birthing sites. So there will be a clinical cart with the stethoscope and examination camera, and it's called the Eyes on Baby project. So this allows the neonatologist to lay eyes on a baby and help prevent unnecessary transfers or stabilize a client before transport. So it just gives them that extra layer where the neonatologist has that specialty to offer. And then the next one is the virtual care primary care clinics. So kind of incorporating virtual care services into the primary care model. So this allows clients to stay closer in their communities and have access to clinicians, so a physician, nurse practitioners, with the assistance of nursing staff, registered nurses, and LPNs are assisting at the client site. The biggest piece with this as well is looking at unattached patients. There is a large population that do not have a nurse practitioner or family doctor. So this allows them to have access to care and have that continuity of care through, a health neighborhood, health hubs is how the health authorities are looking at them. So the last one for me. So, how does it sum up in using virtual care in the nursing practice? So right now it is a balance of that in-person and virtual appointment. So looking at opportunities to offer virtual care and that flexibility to clients to be able to stay in their communities, in their homes, decrease their travel, but also have that access to care, because sometimes virtual care can allow quicker access, but still finding that right balance for in-person. So using the enhanced technologies for the appointments, it's not with our virtual care, it's not just the straight video appointment. We do look at those enhanced technologies, so the auscultations and the examination camera. We are constantly exploring other opportunities. So we're looking at ultrasound and areas like that to help continue to expand the ability to do the virtual appointments and have the extra information for diagnostics. And the appropriateness for virtual care. So it is, it's looking at, is the client themselves suitable, the type of appointment that they need? Can it be done virtually, or does it need to have that physical hand-on assessment? Can another clinician support that assessment, or do they need to be seen face-to-face? And then also looking at their technology to make sure that they have the appropriate technology to be successful as well. So then selecting the right virtual care tools. So we know there's a lot of virtual care tools out there, phone being one of them. Sometimes phone is preferred method for some users. Some clients just want that quick phone call. Other ones would really like to, have that face-to-face with their clinician. So it is finding that right model that works for the client and the provider, and then using, if it's virtual care built into EMR or within remote patient monitoring. It's in the Therapy Assist Online. There's a number of different applications that offer virtual care. So it's finding the right tool for the right time. And the last part is looking at the virtual care opportunities. So a normal face-to-face clinical appointment is certainly, a really standard model that we can offer, but there's also group sessions. So we have advanced technologies that allow groups to come together, do presentations, share information. There's breakout rooms, different opportunities like that. For example, breastfeeding clinics, they've been doing group sessions with virtual care. Education sessions with clients. So diabetes education, they can do it in group, they could do it individual. There's some clinicians that have, recorded the sessions and then we're able to share the information and then do Q&As with their clients after to reiterate the messages. And then also circle of care discussions. So not everybody, I guess the physical distance is not as much of a barrier now. So pulling in, if it's a family member that needs to join with the care team, how do you bring them in to have that discussion? So that's it for me. I'll hand it over to Leah.
All right, so I'm going to focus my side of the conversation around community health and some of the clinical tools that we use in the community health system. So what is community health? So community health encompasses a variety of services, including but not limited to mental health and addictions programs and services, home and community care for clients, health promotion, and health protection. We do see in the community health realm here in Newfoundland and Labrador that there's variations across the province as to what programs and services fall within community health. So what I'm going to talk about today are some of the provincial scope digital tools in the community setting. So three big focus areas will be CRMS, Momentum, and Mid-Access EMR. So CRMS was developed and launched in 1997. It's probably one of our older solutions outside of Meditech here in Newfoundland and Labrador. And it started out just as what the acronym spells out. So CRMS stands for Client and Referral Management System. And that's exactly what started out when we started with CRMS in the beginning. It was literally just client and referral management. It has lots of different features and functions. So it has a variety of client management tools. Again, as I talked about a moment ago, it has referral management. You can provide documentation for your clinical services that you're providing to the client. It has workload management. So it allows you to see the different aspects of your workload that you're providing within your program and your service. Some clinicians have individual workloads where they manage a set of clients. Other clinicians have shared workloads where they share clients between several nurses or a full team. So it allows you to view the number of clients on your workload and who you're servicing on a day-to-day basis. And it also has a scheduling function within the clinic scheduler. We use different features of these parts of CRMS, depending on where you're working. So if you're a public health nurse supporting COVID response right now in the regional health authorities, we have 2 regional health authorities that are using the scheduling software to help book COVID swabbing clinics. So Central and Western Health are 2 of those. It has comprehensive multidisciplinary clinical notes. So if you're a service provider, I'll use public health nurse as an example, who may do interdisciplinary work with some of your clients on the Healthy Beginnings long-term program. So these children may be seeing a behavior management specialist, a child management specialist. They may be receiving services through mental health and addictions, speech language pathology in some regional health authorities. CRMS, for those clinicians in those other services who use CRMS as their documentation tool, It allows you to see that comprehensive flow for a patient. So when you go periods of time in between seeing your clients, if you use certain reports within the system, what it does is it allows you to see that chronologic order of what has happened with the client since you've seen them last. So it's a very effective tool from an information sharing perspective, and it's used quite frequently in the system. Similarly, if you are a home and community care nurse and you have a client who has complex needs, same premise within the community support program in CRMS, you can have that cross access across all the clinical services through the health professional services programs. So your occupational therapy, your physiotherapy, your provincial special assistance program, financial services. If you have clients who are receiving home care, you're able to review and assess if clients need top-ups or additional supports. You can use the financial assessment tools to help you figure that out and work with your social assistance worker on your client's behalf. We have lots of reporting within the system. So there's both front-end reporting that supports your clinical workflows. So our comprehensive notes are one sample of a report that are usable for frontline staff. We have lots of workload reporting, caseload management, referral reporting, as well as some back-end reporting that can help us do some program assessment and monitoring and support the clinical programs in decision-making. So we definitely have lots of opportunity there. Another example from CRMS, which is different from some of our other traditional documentation tools, is we have group client management. So if you're someone who's ever worked in the community sector and you've worked with personal care homes, as an example, you have the ability to both manage individually your clients in the personal care home and their individual records in CRMS, but you also have the ability to do your compliance monitoring and measurement in the group file. So, if you have 10 clients at Personal Care Home ABC, Personal Care Home ABC has a client file as well. So you can do all of your regular monitoring, documentation, your communications with the personal care home in there as well. And that group file or group client also links back to the individual clients who are in the personal care home. So it kind of gives you that full package view of your clients in the personal care home and how you help support the clinical management of those clients in those homes. Thanks, Ashley. So Momentum is another tool that we have within the province. Some of you may have heard of our RI home care tools that we have. So the Momentum tools that we do have are the RI home care and the contact assessments. They're two standardized assessment tools. The RI home care is an older tool and our contact assessment is a more, newer tool. So these tools are developed by RI International. They are a collaborative network of researchers and practitioners from over 35 countries that are committed to promoting evidence-informed clinical practice and policy decision-making. So all of our tools that we use here in the province, both in Momentum and some other tool suites that we have in the acute care and long-term care settings, come from RI International. So the functionality that Momentum gives us in the community setting is it gives us these assessment tools. We do have the ability to go to the client's home and do that assessment right in the home with the client. And that's a big piece of these assessments. You have to be there and viewing what the client can do. So what the system allows us to do is in the community setting, it allows us to actually download the assessment itself for that client and take it offline so that we can go into a client's home without needing Wi-Fi or technology in order to be able to complete the assessment. When the clinician goes out to the home and does the assessment, upon return to the office, what they do is they basically connect their laptop back up to their dock and they can sync that assessment back up to the core software system. So it does provide that improved flexibility to go into areas, especially here in Newfoundland, where we have, low or no Wi-Fi capability or low or no cellular technology. So it is a function that allows us to go out and still service populations of our clients who don't have access that way. It's also used by many of our acute care social workers to start the discharge process into the home care program. And they actually use the Bri Home Care Assessment tool in its web function, so they actually don't need to disconnect and take the assessment offline. So this assessment tool that we do have allows us to function in both worlds. The big thing with the Momentum tool is it does provide quality indicators that can help support and guide program planning. It allows us, we do submit our data to CIHI, so it allows us to have comparative reporting across jurisdictions. So we can compare clients within our home care program in Newfoundland to clients who are in the home care program in British Columbia, as an example. It gives us real-time data. So as you complete your assessment and you submit it, it does provide, it allows you to see if there's any discrepancies in the assessment that you've completed, if things don't align. It allows you to have clinical assessment protocols, which I've got referenced below there, the CAPS to aid in client care planning. And it'll also highlight key areas that you may need to focus on for your client. So these are all of the opportunities that the Momentum tool can bring forward in, care planning and improve quality patient care for your home care clients. And EMR is our newest, latest and greatest tool that we've kind of brought forward since COVID. So while we have EMR in many different areas across the province, what I'm going to focus on talking about here today is the response that we've done for COVID. So we did stand up a provincial deployment. We did do it for influenza campaign last year. So exactly a year ago last month, we stood this up and provided that point of care clinical documentation in our mass vaccine clinics. And this was something we had not had before in a provincial forum. And then, of course, that led into our COVID-19 vaccine campaign that we started in late December last year and are still going through today. Most of you, I'm sure, have either worked in them or been through these clinics. The other thing that we've done as part of this process is to help service the client population. So the patient bookings through Pomelo, which is an interface or an integrated tool for scheduling that works with the EMR. So it allows people to book their appointments online. When they plug in their information, that information then flows directly into the day sheets in EMR. So that allows improved workflow for clinicians when that's done. Reduces the need for registration up front. The data flows for reporting. So I'm sure most of you are aware now, which is, it's a huge piece of effort that has happened in this whole endeavor that we've done in COVID. But your clinical documentation that you're doing in the mass clinics or in smaller sites or acute or long-term care, whether it's EMR or if it's Meditech, that data then flows over to the vaccine certificate and the NL Vax Pass. So I guess it's a huge win when we look at being able to obtain information to support both clinical workflows and support our citizen population here in Newfoundland and Labrador, that your documentation does this as a byproduct. So, the clinical documentation is a huge aspect of what nurses do in the run of a day, especially when it comes to vaccines and moving this piece of work forward. So we also have some additional digital tools that enhance some of our current systems. So I'm not sure if everyone is familiar with both of these, but HealthyNL is something that can bridge data across our systems. So it helps facilitate better sharing and interpretation, of health information among health professionals involved in your care. So what HealthyNL does is it gathers information from multiple different source systems, and there are certain data sets that are available within HealthyNL. So if you're a community-based provider, you can see some of the visit data from Meditech. So if your patient's been in for an outpatient appointment or if they visited the ER, depending on your role access in HealthyNL, you can see some of this information. It also includes lab data, data from the PACS system. So again, depending on your role is what you would be able to have access to in HealthyNL. And then Pharmacy Network is a subset within HealthyNL as well. We often use this in clinical practice when we're looking at med reconciliation. I know many nurses and social workers who do the raw home care assessment will use that to help fill out the medication profile that's in the assessment tool. So it's a check and balance that you can use to review with the patient on what's been dispensed, what they're actually taking, and gives you that kind of full view because it consolidates it from multiple pharmacies if the client tends to use polypharmacy. So using digital tools in community health nursing practice. So, as we've highlighted, I've talked about 3 different clinical documentation tools that are currently used within the province. There are many more smaller clinical tools that use and can help you support your clinical practice throughout your day-to-day. The big thing that I want to highlight is the quality of the data. What you document is key. So especially what we've seen with EMR, we also see this in other clinical documentation systems. Your efforts and your work as a nurse are what help provide improve patient outcomes, improve patient flow, as we see with the vaccine passport. So there's a lot of opportunity from a nursing standpoint to support things moving forward with healthcare in this province.